I'd like to welcome you all to this session on progress in childhood cancer data sharing to inform policy and accelerate care and research. This has been organised by SIOP, the International Society of Paediatric Oncology. We have 4 excellent speakers who are each going to give a 5 to 6 minute resume of their topic area, followed by a dialogue with 4 invited panelists. We'll then have a more general discussion before wrapping up. Some of us, including myself, will be on site during the World Cancer Congress in Geneva in September. So please do come and find me if you'd like to have a follow-up conversation after viewing this webinar in the Digital Congress program. So without further ado, I'd like to now hand over the screen to the first speaker, who's Dr. Sam Volchenboum at the University of Chicago, who's going to talk about the data for the common good, the Paediatric Cancer Data Commons. Over to you, Sam.
Hi, I'm Sam Volchenboum. I'm a pediatric oncologist at the University of Chicago, and I'm going to be talking about the Pediatric Cancer Data Commons. So around the world, despite having high cure rates in high-income countries, almost half of children diagnosed with cancer will die. Half of children who die of cancer will never receive a diagnosis of cancer. And in low and middle income countries like sub-Saharan Africa, this number can approach 57%. A key to improving outcomes in pediatric cancer is collecting, aggregating, and democratizing access to high-quality data. But we have this perfect storm where we have rare diseases where the data are siloed. We rely on manual processes for extracting the data. We have a pervasive lack of standards when we try to answer these difficult research questions. So my group, Data for the Common Good, builds communities, platforms, and ecosystems that maximize how we use data to drive discovery and improve human health. We do this according to the following principles. We want to make sure the data are highly accessible. We want to lift barriers to accessing data, but have the data be highly usable and have it represent the diverse population that we're trying to study. We want to make it easy to use data responsibly. We want to make sure that we can build consensus in the community, ultimately to have impact with how we use the data. Now, Data for the Common Good houses the Pediatric Cancer Data Commons, but we also are working across many other disease areas, including epilepsy, diabetes, Crohn's disease, and other areas. These are some of the pediatric cancer groups that we're working with and the consortia that we helped form and helped run. As you can see, we have almost every pediatric cancer type represented. Each of these consortia have their own governance, and they have their own way of having their stakeholders determine how their data are contributed and how their data are used. We're very much intent on this big tent philosophy. We want to make sure that everybody who wants to can be part of the process. So we involve academic medical centers, pediatric cancer cooperative groups, patient registries, pharmaceutical companies, if they want to come to the table and help us understand how the data are going to be used. The data dictionary process is incredibly important. We bring together experts from all over the world, and we actually discuss all the intricacies of how the data are collected and how will be used, so we can define a common consensus for how we're going to collect the data. At its heart, this is the problem. People can collect data however they want. They can designate things like male and female with 0 or 1, 1 or 0, leading to what you see on the right, which is a set of data that would be completely inoperable between 3 hospitals. And so you can imagine, as you scale this up to more complex areas, how difficult it can be to create interoperable, shareable data. What we do is we come to a common consensus by creating an expert group, in this case for biologics sex, using male, female, and unknown. And then we bind each of those terms to a common element that's in a common dictionary, in this case, the National Cancer Institute's thesaurus. And so here's the code for male. So now you have an unambiguous way of representing this term. And going forward, we want to empower people to use these terms to collect data, so it will then be interoperable with other data sets. This is a list of the cancers that we're working with, and you can see that we have various versions of the data dictionary in progress with multiple data contributors committed for each tumor type. In the center are the names of the consortia that we helped develop and run. We have now over 40,000 cases in the data commons across these diseases, with many projects in progress and papers published. And the most up-to-date version of this chart is always going to be on our website. All of our dictionaries are open source, they're published, they're available for download, and we encourage people to use them because we want people to take our standards and help them power the next generation of data collection and trials. We work with groups all over the world. This is a partial list of the cooperative groups we've been working to share data with. We put in data sharing and use agreements and contributor agreements with groups all over the world, and that's including complying with UK data protection, GDPR, and other requirements. And so we hope to continue this list of collaborations and continue to collect data and centralize it so that it can be harmonized across these different groups. Our structure is that we have this interacting set of consortia I showed you on the lower left. Our group on the right is really a service provider. We take the data and centralize it, but we can only give it out with permission from the consortia that have their own governance and tell us when we can give data out to somebody requesting it. At the top are 3 international advisory groups: a scientific advisory committee, an external advisory board, and an adolescent and young adult research council. And these are groups which help determine and guide us with how we use the data and how we build our data commons. Our data portal is open to the public. We encourage people to come in and use it and search the data that we have. Here is a search looking at different stages of neuroblastoma. You can save your searches and come back to them later. And you can even do things like generate survival curves for different groups that you find. And if you want to request a set of data, it's very easy to do. You put in a data request, it gets reviewed by the executive committee, and then our group will give out the data on their behalf once it's approved. We have dozens of projects in progress and dozens of publications. These are all detailed on our website, and we hope to continue providing data to help drive forward the science of pediatric cancer. We're trying to connect the dots across a patient's lifetime. So while much of the data we have is for patients that were treated for pediatric cancer, we now have some cancer predisposition data in the Commons, and we're also working to get data on secondary malignancies and other late effects. So for us, we think it's important that we take a data-first approach and that we work very hard on the dictionary, very hard on coming to a consensus on how the data will be collected before we take any data. We want to build dictionaries that meet the highly specific needs of researchers and clinicians, and we want to strike that balance between autonomy of having the groups still be able to control their data, but also having the data centralized and harmonized into a single standard. Change management and quality control are very important in making sure that the data that we take and that we offer up is of high quality. And then we put an enormous amount of effort into governance of the data and provenance and understanding how the data were sourced and how they're being used. Our group is about 25 people with developers, computer scientists, project and program managers, regulatory experts, and so forth. And we hope to continue to grow as we build our data commons over many other areas. Our funding comes mostly from foundations and groups like the National Cancer Institute, and we hope to continue to grow our pediatric cancer efforts through these funding methods. And of course, we thank our patients and families that make all of this work possible. Thanks very much.
Thank you, Sam, for an excellent rapid resume of this enormous project. I'd now like to move on to the next speaker, who is Professor Greg Reaman, who is the Scientific Director of the Childhood Cancer Data Initiative at the NCI in the USA. Greg, over to you.
Hi, this is Greg Reaman. I'm glad I have the opportunity to present some information on the NCI's Childhood Cancer Data Initiative, driving progress through patient-level data sharing. The CCDI, the goals of the CCDI were developed by an ad hoc working group, a multidisciplinary, multi-stakeholder working group assembled by the NCI's Board of Scientific Advisors and the National Cancer Advisory Board. The goals were to collect and integrate data from every child and adolescent diagnosed with cancer, regardless of treatment location, and to create a national strategy for molecular characterization, which, when linked to clinical information, could support accuracy of diagnosis and inform the use of appropriate targeted therapy, and to develop a platform and tools to bring together clinical and research data that would accelerate research in childhood cancer. This was made possible by a special congressional appropriation And as I mentioned, this was truly a community effort that launched in 2020. The federated pediatric cancer data ecosystem that was envisioned included all of the types of data shown here, as well as additional data repositories and linked data in the form of the National Childhood Cancer Registry, which extended the coverage of longitudinal follow-up of childhood cancer beyond the SEER program, the Surveillance, Epidemiology, and Result program, to include other state cancer registries. Shown on this slide are some of the NCI-supported pediatric cancer research initiatives, the data from which actually are housed in the CCDI ecosystem, aggregated with the intention that these would be accessible to investigators and could inform the generation of new ideas for intervention and both treatment as well as support of long-term outcomes. This is a diagram of the ecosystem, which demonstrates on the left some of the projects for which genomic and clinical data are included. These data sets are curated and are linked to the Cancer Research Data Commons, or the CRDC. There are a number of knowledge bases that I'll mention in a second, and the data are available through the CCDI hub vision above. Some of the web applications, and these are resources for investigators, include the Childhood Cancer Data Catalog. This is a listing or an inventory of pediatric oncology data resources, which contains over 313 data sets from the US and international sites as well. And the Molecular Targets platform, which is a computable listing of the FDA's relevant molecular target list at the gene level to be used to identify associations between diseases and potential molecular targets for therapeutic intervention. The Molecular Characterization Initiative is one of the major initiatives of the CCDI, providing state-of-the-art molecular characterization at the time of diagnosis at no cost to patients and families. Results returned to participants and treating physicians within 21 days, and samples stored for future research. As of June, over 4,000 patients have been enrolled with results returned to families. As I mentioned, the molecular characterization workflow follows the genomic data from existing genomic data from other pediatric cancer projects, as well as the MCI. The clinical sequencing of the MCI includes whole exome sequencing, Archer fusion analysis, and EPIC methylation. As I mentioned, these assays are performed in a CLIA certified environment, and results returned to families that potentially influence therapy. Results are deposited in the ecosystem, and we're now gearing up to actually perform a deeper dive as far as next-gen sequencing, looking at whole genome sequencing, RNA-seq, proteomics, metabolomics, and single-cell sequencing assays. Another significant program of the CCDI is the Coordinated Rare Pediatric and Young Adult Cancer Initiative. And all childhood cancer, as you know, is rare, but we're focusing on very rare pediatric cancers, less than 2 per million patients at risk per year, to conduct longitudinal epidemiologic cohort studies, natural history studies, to also collect genomic information through the Molecular Characterization Initiative, to develop the critical common data elements to be collected across all cancer diagnoses, with additional elements for select cancers. One of the opportunities presented by this is provided by the National Cancer Institute, White House Cancer Moonshot, and the EU Beat Cancer Plan as part of the EU-US Task Force on Cancer Health Cooperation. So a pediatric cancer demonstration project will include rare pediatric and young adult cancers, and we are beginning this work as we speak. With that, I'll leave you with additional opportunities for information about CCDI, and I look forward to our discussion. Thanks.
So I'd like to introduce Dr. Brenda Mallon, who is the Database and Research Registry Coordinator for the Groupe Franco-Africain d'Oncology Pédiatrique, GFAOP, which is coordinated out of the Institut Gustave Roussy in France. And she's going to talk to us about progress in estimating impact of tumour stage at diagnosis on childhood cancer survival in sub-Saharan Africa. Brenda, over to you.
Thank you. So my presentation is going to be on progress in estimating the impact of tumour stage at diagnosis on childhood cancer survival in sub-Saharan Africa. I have absolutely no conflict of interest. So the Global Initiative for Childhood Cancer has the ambition of 60% survival for children by the year 2030. Underlying the need to scale up in low and middle income countries at hospital-based registries so that we can improve information on epidemiology of childhood cancer. To support some of this, the Groupe Franco-Africain d'Oncology Pédiatrique, which is an ONG based in France, created in the year 2000, supports the establishment of hospital units and staff training for the care of children with cancer in sub-Saharan Africa. So in 2016, this group established a database which is centralized in Gustave Roussy. Today, this database has 13,000 cases registered from 21 centers in 18 countries, mostly stretching from North Africa right down to Madagascar, with a lot of the units are based in Western Africa. So as I say, we started in 2016, and as you can see, the progressively units have joined right up until the most recent, which was Bergeville in Congo in 2024, Bergeville in Ivory Coast and Brazzaville in Congo. And the unit in Bergeville is the second unit in the Ivory Coast. So the French African Registry, we collect information for all children arriving in each one of these units, and data is collected locally and stored centrally. We have about 100 questions that are divided into 11 different sections. And in these sections, information is included on diagnosis, so clinical and confirmed diagnosis. And confirmation, we have been recently uploading all diagnostic information, disease extension at diagnosis and stage, treatment, family and demographic information, and the latest news. So the Toronto Census guidelines, which is established, these international guidelines, in order to standardize data collection and also to allow comparability. So these guidelines are divided really into two main areas, with a T1, which is adapted for countries with less information, and the T2, which basically requires more sophisticated diagnostic techniques. The T1 is really divides into cases that have metastatic disease and non-metastatic disease. And the T2 uses the more sophisticated techniques, but also used from study groups like the National Women's Tumour or the CIOP. So in alignment with that work, the GFOP wanted to look at the data to see if our data was, if it was feasible to implement these Toronto Childhood Cancer Stage Guidelines and estimate the impact of outcome for children. And so we ran a study which was published in 2023. So these Toronto guidelines look at 15 cancer types, and we included 2,133 children into this study for the 15 diagnostic groups. But we were not able to stage, according to the Toronto guidelines, the acute lymphoblastic leukemia cases, nor were we able to stage brain tumors, CNS tumors, because morphology type was not established. So this left us with 1,772 cases that were eligible. And of this group, we were able to stage 89% of the cases. So we wanted to look at how comparable this work was with other international studies, keeping in mind that our study is based on data coming from hospital-based registries. So one study that was run by Max Parkins, and this looked at cases that were registered in population-based registries in Abidjan and in Kampala and Harare. And they worked on 4 different cancer types, and they were able to establish staging for 83%. The Australian study and also the JAC study both run in more high income settings, and they use the T2, mostly T2, and the JAC looked at 2 different cancer types, the nephroblastoma and neuroblastoma, for which they were able to put into the Toronto staging for 95% for the JAC and 88% for the Australian study. So we considered that our work was actually very comparable because we were able to stage the 89%. So then when we looked at overall survival, we started to find limitations in our work, and basically because we were only able to look at survival at 12 months because of missing data. So, however, we were able to come up with 58% of cases that had a survival with 95% confidence intervals at 55 and 60%. We also were able to show that there were very high proportions of stage 3 and stage 4 disease, which we would have considered normal in those settings. Also, survival is better for the localized disease, which is something which we would consider normal also. And unclassified cases were doing less well. So in conclusion, this centralized database did allow for this type of analysis, supporting the World Health Organization Global Initiative for Childhood Cancer. Because often in these countries, this is the only electronic database for childhood cancer in either the region or in the country. The enhancement of this data quality is essential for international comparative studies. Hospital-based registries, while they are a reflection of the children that only come into the hospital, they are important because we are able to get more detailed information on staging and also on diagnosis. We were able to demonstrate that it is possible to stage according to the Toronto guidelines in sub-Saharan African settings, but we were also able to show that it was not possible for 2 of the most frequent cancer types found in high-income countries, such as acute lymphoblastic leukemia and brain tumors. So considering the resource limitations faced in low and middle income countries, we wonder if a review of the current Toronto guidelines for acute lymphoblastic leukemia and central nervous system tumors is necessary. I thank you for your attention.
Thank you very much, Brenda. I'd like to now move on and introduce our final speaker, who is Dr. Eva Steliarova-Foucher, working at IARC in Lyon, France. And Eva's going to update us on the Child Global Initiative for Cancer Registration Improvement.
I'm Eva Steliarova-Foucher, and I am grateful for this opportunity to join this session and speak briefly about the ChildGICR collaboration. I have no conflict of interest to declare. So what is ChildGICR? This stands for Targeting Childhood Cancer through Global Initiative for Cancer Registry Development. GICR provides support to regional partner institutions in the 6 GICR hubs to develop population-based cancer registries, and this was the program running since about 2010. Using this GICR infrastructure and the IARC expertise in coordinating of international studies on childhood cancer, we teamed up with St. Jude Children's Hospital, and this was in 2020, to develop a long-term collaboration focusing on the registration of cancer in children. So combining goals, expertise, and resources available in both institutions, we are currently entering the 5th year of collaboration around 3 work streams, which are implementation in countries, development of educational program, and conduct of topical research studies. So ChildGICR support this way the WHO Global Initiative for Childhood Cancer, which mobilizes resources and political will across the world to improve the outcomes, especially in low resource settings. Strengthening of cancer registration is one of the pillars of the Cure-All framework of this initiative. Because cancer is rare in children, it has long been disregarded in the cancer control programs, although targeted and precise measurements are particularly important for the rare diseases such as childhood cancer. Data can be collected in hospital-based and in population-based cancer registries, and the collaboration of these two registries, types of registries, is important. Population-based data are required to provide accurate information on patterns and trends of cancer incidence and survival. ChildGICR program is envisioned to support population-based cancer registration in particular because the monitoring and evaluation of cancer burden involves several structures requiring sustained governmental support, often on national level, and therefore it is more challenging to maintain than a hospital-based registry. Based on the most recent and largest collaborative study of more than 300 registries, comparable data on childhood cancer incidence were available for less than 14% of the world child population. It is therefore not surprising that the estimates of the annual number of new cancer cases varies considerably according to the assumptions adopted to generate these estimates. For example, Ward and colleagues assert that on a global scale, as many as 43% of cases that occur in a population are never diagnosed. This uncertainty around the global incidence of childhood cancer is one of the foremost reasons why investing in population-based cancer registries is important. Developing a population-based cancer registry is a long-term, open-ended project which requires collaboration of many stakeholders. Therefore, we are starting small, working in several target countries with the local champions, benefiting from the incentive of global initiatives while adapting to local circumstances. We also build capacity through ChildGICR educational program. After having developed teaching materials for 7 topics specific for childhood cancer registration, with contribution by 20 trainers in 2021. We are running training courses in different world regions so that more than 100 professionals will be trained by the end of 2024. We are also conducting several simultaneous research studies, of which I present just one example here. In the chart, we can see the differences in incidence levels reflecting the adopted practice in the registration of CNS tumors. And we can see where non-malignant CNS tumors are not registered, incidence rates are lower, and the international comparison is compromised. This work will support our pledge for the need to register all CNS tumors occurring in children, whether they are invasive or not, in all cancer registries. So we believe that the described activities will contribute to more and better data on childhood cancer, although this endeavor requires involvement of policymakers and committed investments by national governments. You can find more information on our ChildGICR website, and we would also welcome any feedback and expression of interest in building registries together. Thank you for your attention.
Thank you, Eva, for an excellent overview of the work led from IARC. So I'd like to thank the speakers for 4 excellent talks. We're now moving on to the panel discussion. Here are our panelists, and I'm going to invite Parker Moss, who's speaking with experience of a parent of a child with cancer, although he also has experience of scientific research and drug development at a personal level. Parker is going to engage with Sam Volchenboum to talk about the PCDC and its implication for accelerating care and research. So over to you, Sam and Parker.
Well, thank you so much, Kathy. It's lovely to be here. And yes, I was a parent. I lost a beautiful daughter called Vanessa to neuroblastoma a few years ago. And I'm really grateful to Sam for all of the work he does, really in the trenches, battling this hard problem of trying to centralize and also to normalize a huge amount of clinical data around the world. So Sam, I have 2 questions for you. The thing that us parents really care about is that we accelerate better drugs coming to market for our children, and also that there's a higher participation and more effective clinical trial landscape for our children as well. So maybe you could just explain with reference to a few examples of how all of that work of collecting this clinical data is going to lead to better drugs and also better use of those drugs in clinical trials for children with cancer.
Yeah, that's great. And thanks, Parker, for all your help. You've been an incredible resource to the Data Commons, both in leadership of some of our international governance groups, as well as just a great mentor and advisor for us. As you know, most of the data that we've collected has come from closed pediatric clinical trials. And so as such, the data that we have are not directly able to inform future drug development. Where I think that the data will have a big impact is in being able to serve as historic controls for the development of novel agents, and hopefully for helping identify subsets of patients for whom current drugs don't work, who potentially could benefit from further study and further drug development. And as we continue to try to collect broader types of data from electronic health records and directly from patients, I think we'll have a better opportunity to develop a set of data that might help drug developers collect larger sets of data to inform future drug development. So that's a great question, and it's something that we're thinking a lot about.
Okay, thanks, Sam. And actually, that leads to my second question. And this one really looks to the future. So you've mentioned that you want to add more modalities, more data types to your database. And I guess that you're also looking at the advances in technology to help you better analyze. And maybe you could just give us a kind of view of the future in 5 to 8 years. Where do you see this going, and what would you like to be able to achieve?
Yeah, that's a great question, and I hope it's more like 2 to 4 years. But we're really focusing now on a couple important areas. One is direct data extraction from electronic health records, and that's the use of modern tools to pull data from electronic health records, or EHRs, and this really leverages emerging technologies that every hospital should have in place. And where I think we can have a big impact is creating a way for hospitals to extract data with whatever tools they have locally, and then create a landing spot for those data where we can then harmonize it. And so we have several initiatives afoot now with different groups piloting the use of electronic health record extraction tools to pull data out to get a much more comprehensive picture of what a patient has gone through. Another important area that I think is underexplored is direct patient access to their data. So we think going to a patient or a family and getting their consent to mine their health record, and then mining it externally without going through necessarily the hospital itself, but actually using tools and patient access, what we call APIs, is going to be the future of how we collect these data. So think about how some people use an app on their phone to leverage data that they've collected in their Epic instance. We can now leverage those same tools to pull the data out on their behalf and bring it into the electronic health record, to bring it into our commons. I think it's also important to think about how we're going to use high density data, so images, histology, radiology scans. Getting those data, I think, is also going to be critically important, and then linking it all together so that we have a much more complete picture of the patient's journey, I think, is going to be critical, and will then power the next generation of what we're hoping to study, which is late effects, looking at long-term outcomes, long-term follow-up, etc. Thanks, Parker. That's a great question.
Thank you. And just as a parting comment from me, I think because children with cancer are so vulnerable, often regulators and policymakers are quite timid with what they allow to be done with children's data, and often innovations come late. And I would just like to encourage people, anyone who's been to a pediatric cancer ward knows how courageous the children are, and the parents who also tend to be digital natives. And I think often we can be used as really the sharp point of the spear for driving innovation in this space. And that can only be done with programs like yours, Sam. So thank you for your contribution.
Thank you.
Thank you to both. I'd now like to move on to ask Professor Venkatraman Radhakrishnan from the Cancer Institute in Chennai, India, who's also co-chair of the Indian Childhood Cancer Data Initiative, to have a conversation with Greg Reaman about his presentation on the NCI equivalent. Over to you.
Thank you, Dr. Kathy. Thank you, Professor Reaman, for this excellent talk. And the work you're doing is amazing, and looking at genomics data. But I work in a resource-limited setting in a low and middle-income countries. So does NCI plan to have an initiative to get data from LMICs and other resource-limited settings? Because majority of pediatric cancers occur in these regions, and it's important to have diversity in terms of data, and especially genomics. You might not have the same genomics what you would see in a Western world compared to what you would see in America and India. So is there any proposal? And it costs money, doing an NGS, and these patients loading the images takes a lot of money. So what does the future look like for patients in LMICs?
Well, it's a great question, and I would like to say that yes, ultimately, there would be a plan to expand this initiative to low and middle income countries. As I mentioned, this whole initiative is really made possible by a special congressional appropriation. So these are U.S. federal funds to support at least the initiative initially in the United States as perhaps a proof of concept, not only in the pediatric setting, but was really developed as an exemplar for data sharing in oncology in general, because as you know, pediatric oncology is a very collaborative enterprise already. But because of the systems and the networks and the processes that we use to conduct research, these silos exist just as a result of the processes that we currently have. So there's clearly an opportunity for data from outside of the U.S. And from low and middle income countries to be included in the Childhood Cancer Data Catalog, which is basically a knowledge base, a resource of some 313 pediatric cancer data sets from all over the world that are included in the CCDI's ecosystem. But we would expect that the data be in a format that could be made interoperable and usable. Ultimately, will we be able to expand? We're just looking now at opportunities to expand internationally with a coordinated rare pediatric and young adult cancer initiative with the EU as part of the US Cancer Moonshot and the EU Beat Cancer Plan to collect or to actually perform longitudinal observational studies in rare, very rare pediatric cancers, knowing that all pediatric cancer is rare, but I'm talking about the specific tumors that occur in less than 2 per million population at risk. Those diseases are, there are no established treatments for many of these, so we hope that by expanding to the EU and outside of the US, and we actually just last week had a meeting with the National Cancer Center of Japan, and there's interest in collaborating with them as well. And given that these are just observational studies, you know, I think that is something that we may be able to coordinate and somehow accomplish with countries with less resources. But establishing a sort of natural history of many of these rare cancers, I think could allow us to identify potential druggable targets, could certainly inform design of interventional clinical trials in the future, and hopefully, you know, serve as a source of real-world and structured data that we could use as external controls, because in these very rare cancers, randomized clinical trials will be impossible. So, but that's hopefully something that we can talk about in the future, but there's clearly interest.
Thank you, Professor Reaman. And my second question is this data accessible to all investigators or only NCI can access the data? Yes,
and the only reason for collecting and attempting to make the data interoperable is to make it accessible to investigators. So there are opportunities to request data. Some of the data, particularly data associated with PII and some genomic data, is available through restricted access, but that is something, or controlled access, I should say. And there are opportunities using the criterion dbGaP for investigators to become certified to access that data. But it's clearly available to investigators all over the world, not restricted to US investigators. So in low and middle income countries, absolutely.
Thank you, Professor Reaman.
You're welcome.
Thank you to both our questioner and speaker there. I'd now like to invite Dr. Nikhil Bhakhtar, who's a pediatric oncologist in the Department of Global Pediatric Medicine at St. Jude's in the USA, and is also the lead for the African region within the St. Jude Global Alliance. He's going to have a dialogue with Brenda Mallon, who gave the talk from the GFAOP. Over to you, Nikhil.
Thank you so much, Kathy, and thank you to SIOP and the organizers for inviting me. And I really just want to start by congratulating Brenda and the GFAOP team for the incredible work that they've done. I think over the last 5 to 6 years, with the help of Eva and Roberta and the GICC, we've really seen a shift that this false dichotomy between population and hospital-based cancer registries has moved. And so to Brenda, I'm very curious. You mentioned at the end of your presentation that perhaps it's time to rethink the Toronto staging guidelines for ALL. But one of the other roles of hospital-based registries is that couldn't they be used also as a mechanism for surveillance for potential opportunities for quality improvement? And do you see perhaps the lack of ability to identify CNS positivity, not necessarily as a means to change the guidelines, but perhaps identify that there are gaps in the current clinical care, and that really this can then be used for tracking adherence?
Yeah, thank you for the question. There are two things, because what we do within the GFAOP is we are able to identify all the children that are coming in and the diagnoses that are given. But parallel, we also have research programs that are going on. So there are two sort of distinct areas. What we've noticed in the research we did initially is how few, we only had in 3 years 32 cases of brain tumors from 13 different hospitals. So what we do know is that the brain tumors are not actually getting to the services. that's one of the big issues that we've noticed, and that is continuing. For the changes with acute lymphoblastic leukemia, what we know is that the children come in such a bad condition in general, dehydration, malnutrition, etc., and that doing PRs, lumbar puncture, is actually not something that they carry out. So certain issues like that need to be looked at. Also the lack of platelet transfusions in these units, so that all of these things confounded mean that the treatment is actually limited, it is delayed, etc. So looking at outcome, yes, the registry can look at outcome. One of the other things that we do in the registry is actually just management of patient files, so that we can have better follow-up in the long term, that when we go on site visits, looking at some of the management issues of how documentation is happening and why we're not able to get good follow-up on a long term for 36 months or 5 years. So improving all of that so that the data actually improves it long term. So yes.
No, that's wonderful. I mean, what is great about everything that you're sharing is not just that qualitatively we've been talking about many of these aspects for years, but now you have data to actually highlight that. And I'm wondering if you could share perhaps maybe an example, if there is one, where the registry data has now changed practice, or perhaps adjusted some of the clinical parameters because you now have evidence to at least track or monitor what's going on.
Well, as you say, the GFOP, we've been running studies since the year 2000. That was the beginning, and they were feasibility studies. Is it possible to do? And the studies were imitations of studies that were already in existence, like the CEOP study for the nephroblastoma. What we've done is sort of slow down the process, because we're able to, they were feasible, but certain limitations because of the state of the children when they come in. So sometimes, like for Burkitt's lymphoma, where there's a pre-phase that's prolonged before they start with the proper protocol treatment. The same we notice as well, just in management of a nephroblastoma, trying to organize the actual surgeries, often in a different hospital, organizing, getting the pathology, having the actual sample in time, because families would take the sample home because they have to pay. So, all of those things, we had to change just the methodology of running the studies. So those things are actually very practical, have changed sort of how practices, how things are carried out.
Thank you so much. Over to you, Kathy.
Thank you. Now I'd like to introduce our final panelist, who also has a question for Brenda and then Eva, which is Dr. Roberta Ortiz, who is the lead for childhood cancer in the WHO central team in Geneva. Roberta, over to you.
Thank you so much, Kathy, for this invitation. And first of all, congratulate to all the presenters on their great efforts to strengthen childhood cancer surveillance around the world. So again, Dr. Mallon, thank you very much for this very comprehensive presentation. And my question deals more about understanding how the current efforts that have been carried by JFAOP to strengthen facility-based childhood cancer registries and be able to estimate 3-year overall survival in sub-Saharan Africa. How does these efforts link currently to the work that the African Cancer Registry Network has been doing? Because we know the importance of estimating childhood cancer burden is really measured through population-based cancer registries. So how is this efforts being enhanced through your work with JFAOP?
Thank you very much for the question, and it is one of the important issues of this type of registry, that the data is actually not just kept, for studies or for and that it is given to the general public. So one of the things that we have done to improve this situation is that in our site visit program, we have included a visit to the registries when they exist. And in the Afghan 30 registries that are registered with the Afghan hub group, 5 of them are in countries where the GFOP exists. And so far, I think I visited 3 of them. The most recent was in Benin, which is running. So basically, when we go on site, we try to go to the registry and inform them that there is data available on childhood cancer, that is data that is using the ICC coding, and that data is available, but it is not the job of the GFOP. That isn't our interest, is not to provide epidemiological information. We just tell them they exist, and then it is the local service that has the data. It's up to them to share their data. It's not, we actually don't control that, and that's not what we want to do. It's really a local issue. We tell them it exists and encourage them to share. That's what we do.
Thank you very much, Brenda. And I think I'll now following up with Eva. We are really grateful to Eva for her collaboration. As you know, that IARC's role is to deliver on the mandate to be able to compile, estimate, and disseminate comparable data for statistics in cancer overall, worldwide. So Eva, I would like to know, from your presentation, you mentioned the different efforts to strengthen health information systems across the world. But as you know, last year we have been given a mandate by member states to inform on the resolution on cancer prevention and control through an integrated approach, and particularly to inform on the progress of the 3 WHO cancer initiatives. And being WHO GICC, one of the first cancer initiatives, now more than 5 years, we need to report on early progress on achieving the stated target of increasing overall survival for children with cancer to at least 60% around the world. So I'd like to know, from the work that you're currently implementing in these hubs that you mentioned in your presentation, how are those efforts, as Dr. Mallon was sharing with us, how are those efforts to link facility-based cancer registries in childhood cancer units being strengthened to provide population-based cancer surveillance from IARC's collaboration with different countries?
Thank you very much, Roberta, for your question. Yes, so I think there are many components to build or to provide good data on childhood cancer. So ChildGICR project is nested within GICR, which is sort of network of general cancer registries, which is a good thing because that gives us access to data on condition that childhood cancer data within the general registries are not forgotten. So that's one point. Now, the hospital-based cancer registries, which I think the GICC helped a lot to develop. They are really indispensable for getting good data, especially for data on clinical aspects and data on follow-up. Although these still need to be pulled together into population-based perspective, because as mentioned, there are many data sources that population-based cancer registries should put together to be able to provide information on population in general. And these data are important to design policies and plans to beat cancer. So what IARC, in collaboration with St. Jude, what we are doing is to first provide technical help, provide training, so build capacity, work on standardization of data, give some ideas for advocacy, promote data use. But the main interest must come from the countries. And it is true that although childhood cancer is a rare disease and it would be relatively inexpensive to have a population-based registry for childhood cancer in countries. Sometimes we encounter an opinion that from the policymakers that if we have a registration for children, we should have a registration for all cancers as well. And then it's completely different new scale of investment and project. So childhood cancer may serve as a model for countries to start and sort of test how the information system would work and how the data could be collected. But we need data from hospitals, from pathology laboratories, from clinics, from population registries, from mortality databases, and so on. So all this needs to come together, and WHO is very well placed to help exert peer pressure supported by SIOP, UICC, and SenJude, and NCI, and GFR, AOP, because I guess we need to first educate the policymakers and give them good reasons for implementing strategies, and for convincing them that having a population-based cancer registration of specifically for children is very important and very efficient investment. Thank you.
Thank you very much, Eva. Indeed, I think that this is initial 5 years worldwide with the implementation of GICC. We are making that advocacy grow day by day, year by year. Now more than 77 countries are implementing this initiative. So we have this very important momentum and a wonderful platform bringing all together different stakeholders from across the world to be able to make this call for action. We need to strengthen health information systems to inform policy. So thank you very much for your presentation and for your answer. Back to you, Kathy.
Thank you, Roberta. And I think all the speakers and the dialogue with the panelists has illustrated the value of having these data all around the world. And whilst we may not be able to share individual data so easily, I think we can certainly share learning about how to make the best use of data. And Eva, to build on your comment, I think it's about how we can develop population-based cancer registration in close conjunction with clinical services, because ultimately those are the source of the detailed data that everybody wants to know about. I'd just like to add to that really one of the purposes of this session was to highlight the fact that, no problem can be solved unless it's visible through having data associated with it, and we can understand the reasons underlying the challenges and monitor progress. So I think pediatric cancer data is so important for improving care and survival worldwide. I think we're out of time now, so I'd like to wrap up by thanking all of the speakers and all of the panelists. And I hope that you've all found it useful to be part of this session. And as re-emphasize that several of us will be on site in the World Cancer Congress in Geneva, please do come and find us. And any follow-up questions can be sent to myself by email. I'm registered in the World Cancer Congress conference platform. Thank you very much for watching this digital session, and thanks again to the speakers and panelists.
Thanks, everybody.
Thank you. Great.
Thank you.
Bye.
Bye.
Bye-bye.